Okay. Okay, Dr. Kiroba, I'll give you the screen. Maybe you can start.
Yeah, I can. Yeah. Great. Thank you. Thank you, Dr. Abdul Rahman. I'm Kiroba Nagaratnam. I'm a stroke physician in Reading in the United Kingdom. And thank you very much again for inviting us to this meeting and providing us an opportunity to share our experience. So over the next 2 hours, you're going to hear from me, the UK experience, and Alex is going to talk about his experience in Hungary and Sweden. And also the other good thing about is that you would hear from both ends of the story. I'm the stroke physician. I do see stroke patients at the front door, diagnose stroke and the challenges that we face. And also then we refer patients to the interventional radiologist. So I think most of the audience here are interventional neuroradiologists. So, and Alex is going to share his experience of the other end mainly to identify these patients and treat. And also we will share with you some real life scenarios and some cases, interesting cases. So please do step in and ask questions if you would like to while we are going through, and if you feel that question is burning question, and don't wait till the end. I'm sure the moderators will help with that, and if there are no questions, we will have a good discussion at the end. So this is the challenge in the UK. So what you see here is the map of England on the right-hand side. And then we have about 24 neurointerventional centers that are providing mechanical thrombectomy for patients. If you see those circles, the diameters of the circle indicates the number of mechanical thrombectomies that were undertaken between April 2021 and March 2022. So as you can see, there might be like very tiny circles to really large circles. And you can see some centers have only performed one mechanical thrombectomy in the whole year, whereas some centers provided up to 220 mechanical thrombectomies in the year. And you can see the largest circle is around London. That's because there are a number of centers that provide mechanical thrombectomy. But if you look at the whole country,
maybe if the participants can mute, please. Participants can mute their mic, please.
سوي الليمون وسط بالجرجير بدون سكر. كاس وسط ليمون جرجير بدون سكر.
Please mute the mic.
صغير انا ما اكثر حليب بس اخر مره حطيته حليب شويه عشان يفك
Please mute the mics.
Okay.
لا ليمون جرجير.
I don't know if I can stop the mics from my side. Please mute the mics, everybody. Thank you. Keep the mic for Dr. Kiroba.
Okay, thank you. I'll proceed. So the evidence suggests that up to 10% of the patients, of the stroke patients, are eligible for mechanical thrombectomy. But if you see the UK data, only 2.4% of the stroke patients have received mechanical thrombectomy in that year. So we really need to go a lot further to achieve that number of at least about 8 to 10%. And if you also look at the other data that's provided below, the proportion of the patients that are going to a district general stroke center and the proportion of patients who are admitted to an interventional neuro center. So if you see, it's a kind of equal split, 54-45. So half of these people who received mechanical thrombectomy did not actually go to a neuroscience center. They actually went to an acute stroke center, we call it, because these are mostly district general hospitals. They have a stroke center, but they don't have the capability to provide mechanical thrombectomy. So as you know that when the patients go to a hospital that doesn't have mechanical thrombectomy, so they have to go through the long process. We need to diagnose the stroke, do the angiogram, and then after that, refer these patients to the neuroscience center, call the ambulance back, put the patient in the back of the ambulance and send them. So that's a time-consuming process. And the time interval between the patient arriving in this acute stroke center and leaving for mechanical thrombectomy is actually the door in, door out time. And the research suggests that ideally, if you're transferring patients, that door in, door out time should be less than 60 minutes for them to have the same benefit as those patients who are going to the neuro center directly. But if you look at the UK data, at the moment, the door in, door out time is nearly 2 hours and 20 minutes. So we know that every minute we delay, the patients lose 2 million neurons. So, and this challenge is just across the UK, and we are in Reading, one of the acute stroke centers. We do not have the mechanical thrombectomy facility in our hospital. So we do send our patients to either to Oxford or to London Charing Cross Hospital for mechanical thrombectomy. So I'm just going to share next what happened here. If any of you work in a small neuroscience center or small acute hospital, you can realize what happens to the patients. So when the patients arrive and they see a stroke physician, and then what we do, then we need to ask and we need to request radiology from, we need to speak to a radiologist to request a CT angiogram. When the patient has the CT and CTA, and then we discuss the CT angiogram with the radiologist, then when they look at the scans and then confirm the presence of a large vessel occlusion, then we refer the patients for mechanical thrombectomy. So if you look at this process, it's really time consuming, and the patient has to wait for us to have all these discussions. So we initially thought what would reduce this delay is to have an agreement with our radiologist. And we had the agreement to say that instead of us requesting the CT angiogram every time after speaking to the radiologist, we had an agreement with them to say that if a patient comes with signs of acute stroke, we can request both CT and CT angiogram without discussing with the radiologist. So that means patients did not have to go back to have the CT angio. So this is the second improvement we made. When the patients come in, they get the CT and CT angiogram at the same time. While they get on the table in the CT, we do the CT and inject a contrast and do the CT angiogram. That saved us time from patients going between the departments. And when we see the images, we stroke physicians are competent and we're confident to look at a CT scan, a non-contrast CT scan, and exclude bleeding and start thrombolysis. But we're not all fully competent to look at the CT angiogram, especially they can be slightly complex as well, so to look at and then confirm a presence of large vessel occlusion. It depends on the availability of the clinician, the seniority of the clinicians. So if we are not confident about the large vessel occlusion, then we need to walk across the corridor and speak to the radiologist and then make the decision whether we need to refer these patients for mechanical thrombectomy or not. So that again, time consuming, especially if out of hours, then it takes even longer. So what we did, our next step in the quality improvement, we introduced Brainomics artificial intelligence into the stroke pathway. So where that come into place is that the patient come and have the scan, and all the CT and CT angiogram images are processed by Brainomics. So stroke physicians can actually see the images that are processed by Brainomics. It will give us information about the aspect score and if there's presence of LVO or not. And it doesn't take away the radiologist, because we really need them, because sometimes if the images are not processed appropriately, we still need them. However, because what this offers, if the stroke physician is suspecting there is a large vessel occlusion and the AI is also showing there is a large vessel occlusion, so that gives the stroke physician at the front door the confidence to call it a large vessel occlusion and pick up the phone and talk to the neurointerventional center. So that speeds up the process. So next, I'm just going to show you how we use this in real life. As a clinician at front door, if I have an AI solution, what's the benefit of it? So the Brainomics has three components. One is e-aspects, ECTA and ECTP. In our hospital, we use E-aspects and ECTA. So what you see here are the non-contrast CT images that are processed by Brainomics. So you can see in the middle image, what it shows is the areas of the aspect scoring. So as you all know, that there are 10 areas in the brain, each denoted a point, and for each area affected, you take a point away. So 10 out of 10 is a normal scan, and for referring patients for mechanical thrombectomy, you need to have a score of at least 5 or 6. So here is also like, imagine this is a real world scenario. So you will be in the emergency department, there's a scan, lots of people are asking questions, noisy, and then you're going to scroll through the scans and to calculate an aspect score. It can be time consuming, and also there's an rate of variability as well. But what this does is that it gives you the answer straight away. So when I'm on the phone, when the interventional neuroradiologist or neuro ask me like, what's the patient's aspect score, I can look at it and say it's 8. So it's answer, you can make that decision faster. And another thing that it does is it shows the hyperdense sign. It actually indicates if there is hyperdensity in the MCA, it also indicates that. But again, this is an AI algorithm, so we need to be mindful of the fact that it can sometimes get things slightly wrong at times. So for example, if you look at the heat map that shows and then tells us, what the aspect score is. So in our experience, if there's a large vessel occlusion, it gets the aspect score right every single time. But if there isn't a large vessel occlusion, for example, if a patient is an older patient with really atrophied brain with lots of old strokes or small vessel disease in the brain, it can sometimes indicate a wrong area or even the opposite area as an affected area. Therefore, it is really important the clinicians to interpret the AI output in the right context. But if it works in the right context, we can make a decision faster. And also in the hyperdensity, and it's really good at picking up hyperdensities in the MRI angiogram, in the plain CT scans without the angio. But we've had an incident only yesterday morning. What happened is the patient came in with the large vessel occlusion. It did pick up the hyperdensity sign, but then patient had an angiogram, and we needed to repeat the CT scan to see, what's the extent of damage, because the neuroscience center want us to repeat the scan before they accept the patient. What it did, because at this point, patient already had a contrast in the MCA, so it actually just showed the contrast in the MCA as a hyperdensity. So then you need to kind of interpret that in the context. And these are the clinical usage of this. And also what we do in our center, we use these to teach the junior doctors the aspect scoring, because normally if you have you have a scan, then you normally show where these areas are, how do you calculate aspects. But this also gives us an opportunity to actually demarcate the areas clearly and teach them, because this is something that's not, we use it regularly, but it's an additional benefit of it. So that's about the E aspects. And how we use ECTA is okay, so and also and then, because if you see the bottom line, and it identifies also bleeding, because as neuroradiologists and for stroke physicians, spotting a bleeding is the easiest thing, because you can see a white area. We're normally good at it. But what's the advantage of having an AI in addition to that is that because it gives you the volume of the bleed, because as you know that normally we do the ABC divided by 2 method to calculate how much volume of blood there, because if the patients get worse, and we need to know whether this is going worse or better, and also to prognosticate the bleeding. So we need to calculate the volume of the bleeding. So as you can see, that's a bit of a time consuming process that if you're doing it manually. But the advantage of having the AI is that it gives you the volume. And if you're repeating the scan, you can actually compare the volumes and see if it's gone up or down. Usually it doesn't go down, so it stays stable, or if it's going up. So this is an additional benefit of this. And ECTA, so what you see here is the MIPT image of a CT angiogram that you get on your mobile phone. As you can see, it clearly indicates the area of occlusion. But for example, if you're an interventional neuroradiologist and it's a much easier process, you can look at the scan and then make a diagnosis. But if you've got, say, a medical registrar at the front door who is helping with the stroke, and I am a physician on call for making this decision at home, and they can actually look at it and be confidently say that, Dr. Nagaratnam, I have seen it, there is an occlusion. Or I can also look at it even miles away from hospital and then see the scan and then be confident about the diagnosis and then move the patients through the process. But the other thing that we get with this is this, what you see on your right-hand side is actually, it gives you the phase assessment. It actually tells us whether the CT angiogram is at equilibrium or it's an early arterial phase or it's late venous phase. Why is it important if I'm a stroke physician? Because if you look at it, when you see, it also gives us the collateral score. And the problem with the collateral score sometimes is that if it's a very early arterial phase, if it's a large occlusion, it can because it will take for the blood to go into the collaterals. So if we did the scans early, and it can sometimes underestimate the collaterals. So when you see the collateral score and when you assess where the phase assessment is, that in combination, you could actually see how much we can trust the collateral score or it is underestimating. So it's some additional information that we wouldn't normally have, but it provides that for us. And also the third advantage is that how the images that we get on the mobile phone, we get the E aspects, we get the ECTA MIPT, and also we get the multiplanar reconstructions. So as you can see that, even in this scan, we can see that, there's a left internal carotid stenosis, sort of a calcification there. So, this information is helpful when we are referring the patients to interventional neuroradiologists to tell them that, we also see there is carotid stenosis, so that might help them making decisions. And we can do all of it without having to open the laptop when I'm on call at home by just using the mobile phone. And this kind of the quality of the images that we receive. So we have introduced artificial intelligence into the stroke pathway. And what I'm going to now talk about is what's the experience of using it and what's the real patient outcome when we used it in hospitals. What's the outcome when we used it in the acute stroke centers, in the interventional neuroradiology centers or comprehensive stroke centers? How did we use it in a larger area as a system, and what are the benefits? So we did talk about the door in, door out time. The patient comes in, have the investigations, and then go out for mechanical thrombectomy. And this is the door in, door out time. Ideally, that should be less than 60 minutes. For our center, before we introduce artificial intelligence, that door in, door out time for about 140 minutes. Since we introduced the artificial intelligence, that door in, door out time has reduced to 79 minutes, and we saved more than an hour on that. And then because we were able to transfer the patients much quickly to the neuroscience center, so they received the procedure much faster. So as you can see, as a result of it, before introducing artificial intelligence, only 16% of the patients who received mechanical thrombectomy were independent, whereas after the introduction of artificial intelligence, 48% of the patients who received mechanical thrombectomy became independent. That increase is 3 times. It is moderately significant, actually. So that's the real benefit to patients by reducing the transfer time in the stroke pathway. So, but this is the experience from the comprehensive stroke center. These are my colleagues, Paul and Dr. Oliver Spooner. Paul is an interventional radiologist, and Oliver Spooner is a stroke physician. And this is a large stroke network in the east of England. So you can see it's the largest AI-enabled stroke network, and they cover nearly 9 million people, actually. And so what they did, so some of their hospitals this is the Bart's Health, is the neurointerventional center. These are the other hospitals around there, and they send patients to neurointerventional center. Some of the hospitals did have artificial intelligence. The other hospitals did not have Brainomics AI. So what they did, they just wanted to compare the pathway efficiency between these hospitals. And this is what they have found. So the door-in-door time in hospitals who have Brainomics AI was 125 minutes, whereas in hospitals that are sending patients to BARTs but don't have an AI, and their door-in-door time is 185 minutes. So what it saves, that exactly what we found in our hospital, they found when they compare it across the system, which includes several hospitals, and they still showed more than an hour time saving. So what it shows is consistently, when you have an AI, when the stroke physician at the front door make a decision much faster and refer these patients onto the neuroscience center, you save time. And so this experience is where I work. I'm the lead of this network. So we have a thrombectomy network. We call it Thrombectomy Innovation and Transformation Network. So this is London. So the first map, it's east of London, but this is, you can see, this is sort of a northwest of London. That's where we situated. Oxford is here. So this is our neurointerventional center. And we can see there are 5 hospitals around Oxford. We're all sending patients to Oxford for mechanical thrombectomy. And this is Royal Berkshire Hospital where I work. So what we did in 2021, 2021, we implemented artificial intelligence in all these hospitals, and we linked them via cloud network. So that means when a patient has a scan, a CT or CT angiogram in Royal Berkshire Hospital, that images are processed by Brainomics, and simultaneously that can be seen by a neurointervention radiologist and the stroke physician at Oxford. So there's no reason, no delay in transferring images through the normal systems. They can see the images through AI simultaneously, and we can make that decision faster. So, and also we also learn to work together as a network much closer. So look at what happened as a result of it. So this is the number of mechanical thrombectomies that were undertaken by Oxford during 18, 19, and 20. And this is where we introduce artificial intelligence in the pathway. And then you can see the numbers going up after that. But I'm not saying it's all because of AI, but it's mainly because we all work together as a network, and AI was the catalyst to join us all. We were able to refer these patients much quicker. And also Oxford worked harder to extend their hours. So all in combination, that caused this significant increase in the number of patients receiving mechanical thrombectomy in our region. And if you are looking at, because this is, so we all recognize the importance of identifying more patients and sending more patients for mechanical thrombectomy more efficiently. And we would like to introduce artificial intelligence. And this process was actually supported nationally by stroke leadership, because Dr. David Hargroves is a national getting it right first time stroke lead, and he is a great supporter of expediting referral of patients to right places to have the right treatment. And he led this along with Stroke Association and our national stroke lead, Deborah Lowe. They actually produced this national stroke service model. So this is actually, that's what we work as a system to improve the care for the patient. So this is like the guideline that indicates the areas where we need to focus and improve. If you see what we have there, this has been really helpful. We call it NOSIP, National Optimal Stroke Imaging Pathway. So it is clearly defined nationally. This is how we need to image stroke patients when they come to stroke units. And also it clearly indicates where we can use artificial intelligence to improve the detection of large vessel occlusion and refer patients to appropriate centers for mechanical thrombectomy. Why is it important? For example, that if I am a clinician who really want to introduce AI to improve stroke care in my hospital, when I go and talk to the managers, I really need to have some sort of national directive, national support, which actually says that this is useful and this is how you need to use it. And this really can facilitate the adoption of innovation, particularly in this case, artificial intelligence in your hospitals. And that's our experience. This has been really, really a game changer. So quickly, what lessons? So any questions at this time at all? So I can answer, otherwise I can go to the next section.
Well, I was wondering, when you do the CT and CTA, you do the CT perfusion at the same setting if there is no bleeding?
In our center, we do not use CT perfusion. We do only CT and CTA. And if they are late presenting patients and they go to Oxford and have a CT perfusion there, because if you look at UK, most of the hospitals do not have the facility to do the CT perfusion, but all the neuroscience centers can do the CT perfusion. So we only do CT and CTA at the same time, not CTP.
Okay.
Thank you. So just what I'm going to share with you, how we achieve this success as a system, as a network, in terms of improving the care. So number one is that if you want to improve, we need to work collaboratively. We need to engage the local leaders, the trust management. And also, if you're trying to do something to a network of hospitals, some of them are, the leaders, and those hospitals will adapt to new ways of working much faster, but there are always going to be some stragglers. So what you need to do is you need to support each other and collaborate to get everybody at the same level so that you can work as a network much better. And the other issue is that if you're, this is something that you all probably have a huge amount of expertise, but in the UK, the information governance, and it is really a key thing. So we need to be careful. Like, what we do here is that, we look at patients' information, patients' data, and they get shared through the cloud network, and you are going to have access to patient data in your personal mobile phones. So we need to jump through lots of information governance hoops, actually. And that's one of the major barriers here as well, because these information governance rules are different from the different hospitals, although the basic principles are the same, but the way that the governance is monitored and implemented is slightly different. So us sharing with each other these knowledge has been really helpful in terms of implementing AI. And also, you need to be working with the provider who gives the AI solution, because they are absolutely key in integrating this AI seamlessly into the stroke pathway. And also, interoperability of the AI solution is really important. We've had a major issue recently because we got Brainomics, and then we bought 2 new scanners, and they won't talk to Brainomics. So the whole system broke down. So that's also, we need to be mindful. So, when you get something, that make sure that works within the system that you already have, existing softwares should be able to communicate with each other. And also, we need to find the right solution for the right problem. So I'm almost coming to the end of my talk. So this is a good example of what we have achieved across the UK. So you heard about 1 hospital and 2 networks, but this gives you an outline of what we are doing with Brainomics in whole of the UK. Now it's being used in 73 NHS hospitals across 8 integrated stroke delivery networks. More than 250 scans have been processed since it's been introduced. So this is the journey from September 2022 to September 2021. There are more hospitals have come on board since then. And so what's the benefit? So Oxford Academic Health Science Network is actually undertaking a huge evaluation of artificial intelligence in stroke at the moment in England. So as you can see this map, so this is the percentage of mechanical thrombectomy in hospitals that have Brainomix AI. And you can see that's kind of steadily increasing. And it's on average is about 4.2%. But if you look at the national average of mechanical thrombectomy in the UK is at the moment, it's about 2.9%. So what this shows, this graph shows that hospitals that are using AI are likely to provide thrombectomy to more patients compared to hospitals that they don't. But there might be multiple other reasons for why these hospitals with AI are performing better. It may not be the absolute direct effect of AI, but it seemed to have some sort of impact in terms of increasing the number of patients who are receiving mechanical thrombectomy. So thank you. And I'm going to take any questions at this point or remarks, and then I'll pass it to Alex for the other half of the talk.
Okay, thank you very much, Dr. Kiroba, for the presentation. And maybe just two clarification, if you can comment on, when you spoke about the new scanners that you have, and there was a problem. So what problem was it?
So what happens is that, you know, this is very kind of technical terminology, so I'm not completely familiar with that. But what we do is you need to set up the server connections. The Brainomix server is connected to the previous scan. So when the new scan was brought in, the server connection dropped.
Oh.
So because the new scanners couldn't connect to the through the right, you know, because they have ports and various other things, which it's kind of beyond my understanding, but it's kind of very IT technological stuff actually. But what we were told is that because the new scanners couldn't communicate with the Brainomix server, pre-existing server, that's because of some problem with the ports. And it took about, you know, a few weeks for us to then reset everything and they send the images from the new scanners to Brainomix server. So
it's an IT problem, right?
It's an IT problem.
Okay.
That's absolutely true. And also because, you know, that's why I said, like, you know, our ability to work with the provider closely is really, really important. When something like this happens, it can happen at any time, but we should be able to, because, you know, when we call Brainomix and then they were able to talk to our IT team and resolve the issue very quickly, because as you and me are clinicians, we really don't understand the IT issues and can spend quite a lot of time trying to solve these issues.
Yeah.
And that's my point about the ability to work and collaborate with the provider.
Yeah. Another question that to clarify, I did not understand about the data to communicate of patients between the different hospitals to Oxford. You're talking about privacy of patient information, or?
Yeah, absolutely, actually. So because, you know, we need to, because some, even in the UK, they have different sort of agreements, actually. In certain hospitals, they are happy to share the patient date of birth and the hospital number. And some hospitals would say, no, you cannot share identifiable information. You can only share a hospital number and a case number. And there's always a concern that if you are the stroke physician at home and reviewing the images, how do you know that you are looking at the right patient's image? And then how do you overcome that barrier? So then you need to have an extra safety checks in place so that we always check the patient's date of birth before and the hospital number before we make decisions.
Even the age without the date of birth is not accepted?
Oh, some age is accepted, actually.
Okay.
But
what about the sex?
No,
male, female.
Male, female. That's a very interesting question, actually. We had this lots of discussion, but we never thought about, like, you know, sharing that information, because that's also quite helpful information, because, you know, 76-year-old female or 45-year-old male, you know, that could define. But that's an interesting point. We've never had that conversation about sharing that information, but definitely we talked about date of birth and hospital numbers and how much identifiable information you can actually share has always been discussed. Because that's important to look at because of the
Sure. because we have to talk about the patient. I mean, not to confuse between patients, especially different hospitals.
100%.
Yeah. Now, last question for clarification. When we're talking about 4% or 4.5%, you're talking about 4.5% thrombectomies from all stroke patients?
All strokes, absolutely, yeah. Because we're trying to achieve the 10% of all stroke target.
And we're talking about ischemic strokes or all strokes?
We're talking about 10% of ischemic strokes.
But what you have is 4.5%, right?
Yes, yeah. We have a long way to go.
yeah, of course, yeah, I can understand. Yeah. Okay, thank you. I don't know, I don't see any comments in the chat. If there are any comments from the audience. No.
Hello. May I have a question?
Yes, please.
Yes, thank you very much for the presentation. This is Khalil Kurdi from Pairs. I think one thing that is also being somehow an advantage for you in the UK is that you are all within kind of a one national system. The NHS by itself allows this kind of integration and this kind of networking. While if you are dealing with a hospital that is covering several other hospitals of different kind of orientation, I think this will become a bit more difficult to integrate the data. And if you're having problems regarding the patient confidentiality, it's going to be much more complicated if there are different type of hospitals. But definitely, this is obviously it's a good system. But being able to have all the referring centers being able to transmit the data and have access to the AI technology, I think this will be great.
Point well made. You're right, actually, because that's the advantage of having a centralized healthcare system. You're right, and also I talked about the National Optimal Stroke Imaging Pathway and the guidelines. So every hospital in the system will adapt and try to follow those guidelines. And you're right, actually, it's easier to integrate if you're working in the same system. But the reason to share that is that even if you're working with sort of individual hospitals, try to come to some sort of understanding and try to collaborate. It can sometimes, it would definitely be helpful, actually, because if you work together. So, and that's the reason to share. But I can see the challenges that can come, arise as a result of working as individual hospitals.
Yeah,
I don't know, but system in Saudi, is that individual hospitals, is that right?
Yeah, I mean, it's true that at least theoretically, the Ministry of Health hospitals are under the same umbrella and they cover the majority of cases, but there are other also kind of tertiary care centers and let's say comprehensive stroke centers that are not within the same network, and having them covering different types of hospital will be a challenge, because companies will, the company will have to kind of have separate type of agreements and contracts with different providers to be able to have it within the same network.
I might jump in here, Khalil, because we had the same problem in Hungary. A lot of different hospitals, quite an autonomous islands of hospitals, and it's still doable to have an agreement and to cover them under one umbrella, under one AI umbrella. But I will talk about it in the later slide. So it is doable.
Yeah, sure, great, thank you.
Okay, I don't think that I did not see anything in the chat. Maybe we can continue, Dr. Alex, and maybe we'll leave time later for other questions if they come later.
Thank you so much, Dr. Abdurrahman.
Thank you.
I'm just wondering, I shared my screen. Yes, I shared my screen. So if it's visible now, so.
Yeah, I see the map.
Okay. So actually, now I'm working in Sweden. So I've set up an thrombectomy center here in the middle in Örebro. Sweden itself, it's a large European country by European standards, but it's dwarfed by kingdoms of Saudi Arabia. So when we're talking about Sweden, you can take like the whole Sweden and put it on on the coastline of Saudi Arabia, and this is it, and 300 kilometers into the land. So it is a large country, but you have much bigger geographical problems than we have in Sweden. Anyway, here you can see one thrombectomy center with the red. This is a rural thrombectomy center, and the referring hospitals around. And those small numbers that are representing the yearly ischemic stroke volume at each and every referring hospital. So stroke incidence in Sweden is quite high. It's 174 in our region, and in our neighboring region here on the West Banks, it's 225, and our eastern region have 185 per 100,000. So it's quite a large number. So in this whole area, we are counting about 1,726 ischemic strokes per year for the population of around 900,000. And this area is covering 44,000 square kilometers. So the biggest problem was that all the hospitals had a quite conservative stance. So we made something that bring together the hospitals, a communication system, a referring system that I will show you just in a couple of seconds. And we implemented AI solutions too, because we wanted to know what's happening in all the referring hospitals. And what's good with the AI-enabled solutions, that you can have your mobile phone and you can have the notifications if they're enabled. So you can have all the notifications about stroke patients getting a scan, a CT scan. So when there is a scan happening in the region, we are getting notified. But we also have done other improvements in the system. So if a patient gets a stroke somewhere in the region, so obviously the first thing that's happening is the ambulance rushes to the patient and do a pre-hospital evaluation of the patient. And what we are using for this, we're using an app from Join Medical, from Alma Medical. It's called Join TriJab. So obviously the ambulance personnel, they are doing the fast ED score, which is a rapid assessment of a stroke patient. And then they're assessing the patient and sending this score to our mobile phones. So it's in Swedish, but we are getting a notification about that there is a stroke patient in the region. So the closest PSC, a primary stroke center, should prepare itself to accepting this patient. So it's a pre-registration of patients, and we get the data about the possibility of large vessel occlusion. So in this case, we get a patient with a high probability of large vessel occlusion. The patient is transferred to the closest, geographically closest primary stroke center with thrombolysis capabilities. Through the same app, we can follow the ambulance, so we can see at each and every point where is the ambulance, and we can communicate with the ambulance. If there is a need, we can have a video call with the ambulance and to see the patient, to do a full NIHS scoring for the patient. So obviously, if the ambulance arrives, it's mandatory for the ambulance personnel to wait for all the scans being done, because if the patient needs to be transferred toward the comprehensive stroke center, it takes a lot of time to get another ambulance team, and so it's better for everybody and for the patient to that the ambulance team is waiting for the patient. We have a scan time, so which is 15 minutes. So in 15 minutes, we need to deliver all the 3 sequences. We set up our system in a way that all the stroke patients getting CTs, native CTs, CT perfusions, and CT angios. So we took out all the dichotomies from the system. So if a patient gets in with a stroke code, and the neurologist thinks that it is a stroke, because the neurologist team is always meeting the patient at the CT department. So we're bypassing the ER. The neurologist team is at the CT department. They're doing an NIHS scoring.
Dr. Alex, it's the same slide?
Yeah, it's the same slide.
Okay. Or just wondering, the slides are not moving.
Yeah, now it's moving. Now it's getting to move.
Okay.
We are doing the first scan. And the first scan is we're getting
Still not moving, Dr. Alex. Huh?
Still not moving. Now it's moving.
No, it's the same slide.
Sorry, okay.
Because I still have Dr. Kiroba. He's having the sharing screen. Not let me.
Okay.
Did you request to
once again?
Yeah, you have to share the screen. I don't see a request to share.
I just did. I just shared my own screen. Let me do it once again.
Yes. Okay. I see your mouse. You're moving the mouse now.
Now I'm moving the mouse over the map.
Because I see that Dr. Kiroba still controlling the screen. Now the mouse is moving. Okay. Can you try to change?
Yes, it tries to change. Now the mouse, I have the mouse here.
Okay.
I'm moving the mouse and I have a video which is running on my screen. So I actively sharing the screen now. But I think Dr. Kiroba's slides are also shared.
Let me see. Dr. Kiroba, can you unshare?
So I have given up the control already. So I'm only viewing your screen rather than controlling it.
Do you want me to advance the screen, Dr. Alex? You tell me next.
If you just can stop the sharing, then I can share my own screen here.
Let me see. Okay.
Now I might need to.
Now you share. Try.
Yes.
Okay, Alex. Now it's your screen, right?
Yeah. Now it's moving. Is it?
Yes. Okay.
Okay. Sorry for that. So the first thing that there is a patient who got a stroke. So the ambulance we use. Now you might see the video. So this is the interface of the ambulance software or the ambulance app. This is the Triage app. So they are sending the preliminary data about the patient to our. It's like a messenger team. We have this joint Triage application. So we get an idea about what patient is coming to the hospital. So in this case, we're transferring the patient to the closest PSC. So you can see the patient is transferred to the closest PSC here. The ambulance team is waiting for the patient, and we are doing all three sequences. So native CT, CT perfusion, and CT angio. So obviously, when the CT is done, it's the Brainomics software is really fast. So we're getting the images, the AI images at the same time when they are coming into the workstations. So if you're standing by the workstation, you're getting the notification at the same time. So it doesn't take too much time to process the images. And then you have not only the aspect score, but you have the volume of the infarct. On the native CTs, you have also, if there is a hyperdense vessel sign, you get information about the hyperdense vessel sign, how long is it, and then we are proceeding with the CT perfusion. So in this case, we see a large perfusion deficit, which is will be an distal IC occlusion and ICT occlusion. We also see that you can get the information about the time activity curves and about the patient motion. So in this case, also the software is reminding you that you need to take those, you need to take this data with a grain of salt because it was a lot of patient movement at this case. But anyway, it's a usable data. And for all the patients, we are doing MRIs as a follow-up after thrombectomies. So we see a good good relation between the CTP data that we get and between the MRI, even if there is a lot of movement artifacts. So, and we are proceeding with the CT angio. And in this case, the system has already flagged the occlusion at the CT angio. And what's good that you don't need to, you're not bound to a workstation or to a computer. So we are getting all the MPR reconstructions, the coronal, sagittal, and the axial reconstructions. So we can look at which artery is occluded, how the anatomy looks like, if there is any carotid stenosis, the dissections. So what should we prepare for? So obviously this data is coming right to us, and you can see the carotid T occlusion here. So the data is coming to us even before we talk with the neurologist. So after that, you have the possibility to communicate the patient's symptoms also in the app, but obviously you can take up the phone and call the neurointerventionalist. But what the system does is almost bypassing the radiologist or the radiology department, because then the neurology specialist contacting the neurointerventionalist directly, and the neurointerventionalist already seeing the images. So it takes all of the guesswork out of the system, because otherwise the classical system looks like that you need to do a native CT, you need to have a radiologist on board that's looking at the native CT actively, with the neurologist giving the RTPA or TNK. And then you might request a CT angio or a CT perfusion in some cases. But this whole system streamlines this process and takes down the door in, door out times well below 30 minutes now. So with the modern communication possibilities, you can also communicate with helicopters, for example. So from this region, most of the patients get transferred via helicopter. And it takes about 30-40 minutes to transfer the patients to CSC, or 1.5 hours or 1 hour to 20 minutes with the ambulance. And then the patient gets the thrombectomy. So we started this system in 2021 in June. So we have a whole full year now in 2022. So we did all the data capture from the system, and now we are seeing that in our small region with 3 referring hospitals, we've done 116 thrombectomies, which is 21% of all ischemic strokes, and the thrombectomy incidence is 37 per 100,000. And our neighboring region, we did 14% of all ischemic strokes was recanalized with thrombectomy, and this is 31 per 100,000 incidence. So when we look at the national data, this is the first column is the thrombolysis, the second is thrombolysis and thrombectomy only, and the total reperfusion grade. Our region was the last. This is the data from 2020. So we see the all recanalization rate with the thrombolysis and thrombectomy is 8%, and the our neighboring region, which is the Värmland region, they had 15% of recanalization. So after a year of work, I might say that we've gone from 8% to 29% for total reperfusion, because our thrombolysis rates were not really changing that much, and our neighboring region had the same uptick from 15 to 27%. So it's interesting, by only giving more effectivity in hands, the system moves itself, because now we're seeing that neurologists are more and more engaged to send the patients, and also we see that the radiologists have more and more engagement with those patients, and the AI, they're using AI as a crutch, so it's like an aid. And mostly for those remote hospitals who are not having that much experience with CT angios and CT perfusions, they have a direct line to the neurointerventionalist or to the radiology department of the CSC. They can get help anytime. So if it's 2 in the morning and there is a radiology resident who is not really keen on working with a stroke patient and not really experienced in that, so he or she can get help in 2 minutes. And moving forward, these are the things that we changed, and it's coming from the NOSIP from the UK. And what's interesting that we came to the same conclusion in Sweden and in the UK, what needs to be done to have a much more effective system. So you need an early and detailed notification. You need to prepare the hospital for the patient, so the pre-arrival preparation and pre-registration of the patient. You need to meet the patient by a stroke team. So the neurologists are meeting the patient at the CT department. And the ambulance crew asked to wait while the patient is imaged, because if we are not doing this, then we might lose 20, 30, even 40 minutes. So all image acquisitions should be taken at the same sitting. So we don't have to request more and more imaging after the fact. So we're doing all the 3 sequences in one run. Immediate
sorry, Dr. Alex. Sorry, I think there are some people. Please mute your mics, please. Candidates, mute your mics. Please mute your mics. Let the speaker continue. Please mute your mic. Please mute your mic. Thank you. Go ahead, Dr. Alex. I apologize.
Okay, thank you. Thank you. So, if you do the immediate brain scan interpretation with use of AI support, so you're basically equalizing the experience differences between remote hospitals and the CSCs. You have the immediate data access also from CSCs. EV thrombolysis should be commenced in imaging department if indicated. We're using TNK for the remote hospitals, and we're using RTPA in the CSC because TNK is more convenient for us with the bolus dose, so we don't need to transfer the patient with the active infusion. And it's really beneficial to have real-time image transmission. And we need to transfer the patient obviously with the large resolutions to high priority transport should be done to the CSCs. It's also it sounds obvious, but it can be that most of the ambulance departments and ambulance teams transport the patient as a low priority because it's secondary transport, not primary transport from the site to the hospital. So between hospitals, and it was a problem in Hungary too that we had secondary transport without high priority. So after implementing such a system, and obviously what we are doing here is the top diagram is the classical way of dealing with stroke patients. And when you're implementing the AI, so the AI is basically taking out the information that makes it accessible for the radiologist, for the neurointerventionist, and also for the neurologist. So it's really easy and convenient way of sharing the information and getting access to information. And also it means that you have a crutch. You have always, you can turn on or turn off your notifications about the AI data. So if you want the AI data being represented in your app, then you can flag it, and you can have your heat maps and your occlusions and volumes on CTPs. And we all know, maybe you all know, you're familiar with this article. So every 10 minutes of delay would render 2 months of good life quality useless for the patient. So the patients lose 2 months of good quality life with every 10 minutes of delay. It's also very important to collect the data. So when you can see this skewed image, this is the pre-hospital, intra-hospital, and the algorithm in the lab. So if you might and if you may, you should collect the data from for demographics, clinical imaging, outcome data, interventional and economical data to create a data pool for later use and also for national quality registries. We have 2 national quality registries. One is for all stroke patients for ischemic and hemorrhagic, and the other one is for those stroke patients who were treated with thrombectomy. this one from that. So we have comparable outcome data. The first column is NIHS before and after, before. The other one, the NIHS after. On the top, you can see the national data, and on the bottom, we can see our data. And it means that we are treating higher volume patients compared to other hospitals, but we have the same outcome data. It means that there is an under-treatment going on in other hospitals. We didn't lose any effectivity with elevating the volume. So here I can show like a real-world use of the Brainomics AI system. Actually, I was in a restaurant with my colleague, and we got a notification about the patient, and it takes about 1.5 minutes, maybe 2 minutes to take a stand. Should we do a thrombectomy or not? So I just invited you to look at the video. You will see that like the real life, what's happening in the real life at the left side on the screen, and on the right side it will be an image capture from the app. So basically, this is it. You can have your stroke patient, and you can make a decision in 2 minutes, basically according to the images on a mobile phone on a sunny afternoon, even if your sun glaring at your phone screen, because otherwise it's not that easy to discern and to make a good decision about the aspect score, for example, without the help of such devices. Also, you can see and you can pinpoint the region of occlusion here. So you can see the sagittal reconstructions of this CT, and we can see that there is a large M2 dominant branch which is occluded. Also, you can see the timestamps here. So the patient was in to the primary stroke center at 14:04, was thrombolized 14:23. And the route was 14:34. So it took 30 minutes with the thrombolysis to get all these 3 scans done, to give thrombolysis, and to roll the patient to the comprehensive stroke center. So then the comprehensive stroke center is 24 minutes later. Is quite a short drive from our referring hospital. It's one of the closest one, and then obviously we can look at the perfusion data here in the map. You can see that this was not the perfect perfusion because the time activity curves are way off. There was a patient motion too. So you should take this DT perfusion data with a grain of salt. We can move on, and also in this app you can message, and you can have the clinical data too. So the neurologist having the same app, having the access to the same app, they can just can calculate the NIHS scores. It's really handy because you don't need any paper. You can do it in the app, and you can also enter the times, which is good for data collection later. So here you can see a normal CT reconstruction of the same patient, You can see the right side occlusion of dominant M2 branch. And the thrombectomy was done with a double stent reverse because it was in a bifurcation, and in those cases we use double stent reverse for bifurcational thrombectomies, and it was a first best effect. And this is the site of the occlusion. You can see that this large dominant M2 vessel occluding both precentral, central, and the angular branches.
Yeah,
and
Dr. Alex. The hypoperfusion area was not very clear, the hypoperfusion, not the infarction.
The hypoperfusion.
Yeah.
Yeah, it was not really clear because the biggest problem that we had with this patient is that he moved quite a bit, and the perfusion was not really a good quality perfusion. So the time activity curves was truncated.
Okay.
So that was the biggest problem with this scan. And if there is you have a warning like this, that slow sampling may have reduced accuracy and truncated acquisition may have reduced accuracy. So you have a notification about this too. So the app notifies you that, okay, this one is not a good quality, so you shouldn't accept it probably.
Yeah, okay, but the CTA was good.
The CTA was good, yes, at least.
Yes.
But it happens. It happens with the patients with stroke that they move around. Then the algorithm is trying to correct for the motion, but the biggest problem is when you have a rotational motion it's really hard to correct. But you are completely right that the CTP data was not really good. So. Do you have any questions at this point?
Well, it's just that it looks like you have a well-organized stroke service nationwide, or I don't know, because you have connection with the ambulance, with the helicopter. So it's a different system, right?
Yeah, actually, we made that system working. So in 2 years, we implemented the communicational system between ambulance, and so the pre-hospital and hospital communicational system, which added a lot to the system. And we also wanted to know what happens in the region. So I wanted to have my hands on the pulse of the region, or you might say that you were the spider in the web. So if the web wiggles, you know what's happening in the region. So you can, even if there is a large vessel occlusion, which was not documented or not seen by the radiologist or neurologist, you can ring them that, guys, you have a large vessel occlusion, we are here to help. So it might take a lot of notifications.
Yeah, but it shows that everybody is on board and willing to improve. Now, the other question is, I was wondering, do you do like in UK, you do the CTA and the perfusion all in comprehensive stroke center, or?
We do perfusion in all centers. So
okay, so
really,
so it's one study, yeah.
It's one study. We are not repeating the perfusion because if you think about perfusion in most studies used as an exclusion tool. We use perfusion as an inclusion tool. So we are taking account all the studies that came recently, like with large ischemic core, the distals. We are self in a distal study. So we are doing the perfusion for have a better understanding of the pathophysiology, but not to exclude the patients. So it was a mindset shift from that's why perfusion being as one of the most important scans that we are doing. So if it will be a possibility, and you can ask my neurologist if they would to choose which sequences they will have, it will be the native CT and the perfusion. Angio, it's questionable because we are doing angios anyway, and the only thing that you are missing is the vessels in the neck vessels, so vertebrals and carotids. But yeah, the thing is that now the neurologist cannot live without perfusion, so it's interesting.
Okay, a question which is maybe not very clear. What about your experience of brainomics in the posterior circulation?
Sorry.
I think some candidates are not muted if they have a question. If not, maybe you can mute it if you're not asking. I don't see. No, my question was, Dr. Alex, about your experience of brainomics in the posterior circulation in the basilar.
Yeah, actually, it's improved quite a bit. Now we get this the sequencing of the native CTs, but we are not getting the results yet. For a CT perfusion, it works, but when you compare it to the single via, for example, we are mostly using Siemens systems. Then the sensitivity is a bit lower compared to the single via, but the specificity is higher. So you can, with single via, if you have a good perfusion, and in all Sweden, we're using new CT equipment. So it means that all the CT equipment is capable of doing whole brain perfusion. So we're getting all the whole brain perfusion image. And what we are getting, that even the small perfusion deficits in the brainstem, sometimes you can see it with the single via, but the sensitivity for single via is quite high, so the specificity will be quite low. On the other hand, or the cerebellar perfusion disturbances, the brainomics catching them quite well, and have quite a couple of cases to show that. But you're getting the information from brainomics too. So if it's a pike occlusion or SC occlusion, you get the perfusion deficit on the maps and the penumbra and ischemic core maps. Okay,
maybe a question, either you or Dr. Kiroba, I don't know. Since you have multiple hospitals connected, and so all the scanning are going to a virtual network or virtual server controlled by in UK, the NHS, and your case, maybe another from health, from your, I don't know who's owning the server.
So I can say in the UK, so if you have all the scan images that are done in a hospital owned by the hospital, actually, so that's not shared anywhere at all. So the source images stay with the hospital. But
yes,
when you share the images through Brainomics server, so that actually stays in the Brainomics cloud server.
So it's a Brainomics cloud server, or it's a virtual server in the hospital? Brainomics is inside.
That's right. Yes, that's correct. Because you do not have anything physically attached in the hospital, so everything's sent to a server which is virtual. So yeah.
But the data that is sent to the Brainomics, is it with Brainomics or?
Yeah, it is with Brainomics, but this is why, because this is what I said, like the governance arrangements actually, because if the Brainomics will provide all the information about what protections do they have in terms of, because all we can say is that in our experience, if we sent an image to Brainomics server, and even Brainomics cannot then access that actually, they can only see the number of scans that are being sent to their server, but they won't be able to see or access any of those scans within their server.
But they have the data, right?
They will have the data about the number of scans, which hospital they are sent from, and whether there's a large vessel occlusion or not. So they can get those sort of a meta sort of data, but they will not have access to the real scans of individual patients.
Okay, and this is the same in Sweden?
Yeah, in Sweden, we have physical servers in the hospital VPN network. So we are gathering all the scans on those servers.
So you have like a central server for all hospitals?
Yeah, yes. Now we have a central server at our hospital. So all the hospitals uploading their data. We have an interconnected PACS system, so it was quite easy to do. In Sweden, all the hospitals are interconnected. In Hungary, it was a little bit different because in Hungary, it was no connection between hospitals. So image sharing was more like WhatsApp or Messenger. But in Sweden, you have...
Which packs that you have in Sweden? Which packs?
We have a homemade packs, which called Sectra.
Sectra, okay.
Sectra. And it's a Swedish made.
Okay.
The same here in the UK as well. So we do have an integrated pack system. We use Insignia packs actually in our region.
Also all integrated, huh?
All integrated. But also we have another system of sending images between hospitals that are not interconnected by PAC system. We call it image export portal. And that can be very time consuming. It's sometimes, if the portal is busy, it can take up to about 25-30 minutes for the scans to go to the hospitals. So that's why the AI cloud server is really quick way of transmitting the images and for decision making.
Okay. Any questions from the audience?
I have a question.
Yes, please, Dr.
Yeah, one more question. What about actually? Do you save this data into the packs of each patient file in the hospital for decision making, or this is only on the cloud and you don't save any of this data?
The data gets sent back to the packs. So all the AI imaging data sent back to the PACS. So the PACS has the data, and you own the data, or the patient owns the data, but the hospital, you have all the data on the hospital network.
Each patient's data is actually saved in the file, in the PACS file of the images in
the patient,
in particular hospital that they came from initially, correct?
Yeah.
Yes.
Yeah.
Yes.
And maybe even in the comprehensive stroke center as well. So it's being saved in the initial referring acute stroke center as well as the comprehensive stroke center.
Yes, because we are on the same network, so it's quite easy. We see all the referring center data flow in our own DICOM query networks. So I can query a patient from another hospital which is in the same region, and I can ask for a patient to have the images transferred from another region. But in Hungary, which was more akin system to the UK, it's also the same. You get the patient the image transfer back to the mother hospital, to the mothership, when from where the patient came from. So you get it both ways.
Yeah, and also in the UK as well. So you can have access to the AI images in the patient's packs. Very similar way. Very similar to Sweden.
Okay. One more question. Is there any issues related to some patients that the AI, for example, recommendation is not for thrombectomy, and there are some decisions are being made for thrombectomy regarding any potential for medical legal issues, for example? Because this might come up at some point.
Yeah, the AI is not a decision.
Example, sorry, I did not understand what you mean, Dr. Khalil.
Yani, let's say that the AI is making kind of a borderline not thrombectomy candidate, and the physicians see that this is a thrombectomy, let's say for a branch occlusion of MCA or something like that, and thrombectomy is being done, and there is a complication or there is a question about using AI as a guideline. I mean, it can work both ways. AI is recommending thrombectomy, you don't do it for whatever reason, or the opposite, where AI is not recommending thrombectomy and is being done based on other clinical factors. Will that be an issue and medical legal issue as well?
I can take this one, because what we are talking about is descriptive AI. So the AI is not making any decisions. So it just help you to see what's the status of the patient. So you can see better. It's like an augmented reality, actually, that you have some crutches, you have some aids to make a good decision. But at the end of the day, the AI is not telling you that you should do this and this or that. Obviously, if you take, let's say, an example, you have a cutoff of 60 milliliters of large infarcts, and your AI is saying that this patient is 59 milliliter large infarct, and you take on the patient, do the thrombectomy, you have a bleeding, and then the patient files for a complaint. it can happen also with single via, and it shouldn't be only AI problem. So it's a medical legal issue problem. But since you're not getting any decision making, you're only having a decision making aid. Not the decision is at the neurointerventionalist or at the neurologist table. So when we're moving through the ranks and we are going to the predictive AI, then you have a prediction of what should you do. Then it's another question, but now you only have a description of what you're seeing. So it's an augmented reality of the description of the images that you're already seeing. So we are getting more and more complaints about not doing the thrombectomy. That's the problem. Not about doing the thrombectomy and failing or having a complication, but more about not doing the thrombectomy and then the patient's family files for a complaint. So this is mostly the other way around.
Exactly. I mean, this is both of them are possibilities that they might happen. I mean, it's clearly yes. AI is for now, it is not the decision making, but you know, access to this information, access of public to this information will also mean that they are, you know, aware that this might have been an issue. I mean, clearly, and clearly we're also moving into new eras like the low aspect score patients. Those have been in the system, accepted as a non you know, thrombectomy candidates, but also we're kind of changing that based on the new studies and the results. So this will also be kind of a new thing that we will have to face.
Yeah, it's putting a lot of pressure on the thrombectomy centers all around the world, those new studies. So I see more problems here that we cannot cope with the coming volume, rather than accepting a patient and failing. It happens with everybody. But obviously there are other legal systems than in the US, other legal system in Sweden. In Sweden, the patients are not really, they're not likely that the patients use the doctor. So it's not really happening. But compared to the US, I can see a larger problem there. And
how many neurointerventionists you are on call in your hospital, Dr. Alex?
I started by myself for the first year. Now we are 3. So the first year, 1 year and 2 months, I was alone. Then I had 2 fellows, but now they're doing thrombectomies themselves. It's 1 neurologist colleague and 1 cardiologist. So we have a much more inclusive environment for learning neurointervention now in Sweden than it was before. So
and
now
you cover all
several specialties.
You cover all the other hospitals that you
yes,
showed
we are
in the
covering
map?
now. We're covering yes, we're covering all of them.
Do you have cardiology service, emergency, PCIs, coronary stenting?
Yes.
And they are on site?
Yes.
Fellows?
Can
they help?
Our setup is, yes, absolutely. So our setup looks like this. We have 4 labs on the same corridor. So we have 1 neurointervention lab, 2 cardiology lab, 1 vascular intervention lab, and 1 EP lab, which can be used for other things. So it's actually 5 labs. And we have the same nurse team for all the labs. So it's 20 nurses, and they're covering the peripheral vascular, neuro, and PCI.
Okay, interesting. Interesting.
So then it's also it came that we accepted the cardiologist colleague who was very interested. He went through the ESMINT course for neurointervention, and then he was quite experienced cardiologist. And for him, it took maybe 12 months, 14 months to be completely reliable and doing thrombectomies on himself. So, but it was more for him. It was more imaging and neurology, and less catheterizations of the brain vessels, because he was quite good at it. And
the brainomics is helping a lot, right?
For him, it's also helping a lot, because now he can take a decision. So it's yes, I would say yes, even without brainomics. So he's doing well, but obviously with it, and obviously it also helps for neurologists, because neurologists now get access to the information which was like hidden in the radiologist's mind. So you're obviously equalizing the experience difference between a good radiologist and a neurology resident, for example. So, but how we did the system, the system is specialist only system. So a resident cannot refer a patient to a specialist. So it should be, we kept it on the specialist, on the specialist level. Because otherwise you can include patients with false positives, false negatives, which is obviously not good. But we're keeping the conversation on the specialist level.
Well, that's been very informative, and the question is that, is there any? I can see that the brainomics now spread in UK, and do we have any studies showing? Like trials for the brainomics?
Yes, there are a couple of studies, and maybe Kiruba, you can take it because you were in one of the who was writing the studies also.
Okay. Yeah. So yeah, I can talk about. So one, we're just about to publish the data that I have shared with you about using the brainomics and how it reduced the door and door out time and translated into patient benefits. And also we have undertaken, some of the information is going to be in this publication, which we are, it's on the screen. So we're just going to launch the ESOC 2023. So here we are going to share all the evidence as a result of this collaboration with brainomics with the help of Accelerated Access Collaborative. We call it an NHS-AI award. So all the specialists and all the stakeholders come together. We're putting together everything that we've experienced, and there's going to be data and some studies will be included in this. What we have done also, so we did another study, which we haven't published, but we are presenting as a poster in the ESOC. What we did, we compared the LVO detection by brainomics versus the reporting of the interventional or neuroradiologist. So we wanted to see what's the positive and negative predictive value of the LVO detection by brainomics. So, and what we found is that it's highly specific. So the negative predictive value just reaches around about kind of 90%. So when the brainomics says that there isn't an occlusion, it's very unlikely there is going to be an occlusion. So that's really useful. But then now we are looking at the data slightly more deeply into where these occlusions were, whether this is better at predicting if the occlusion is more proximal than distal or not. We are now delving slightly deeply into the data. So that's we have done locally. So we are now setting up another trial to look at the E aspects and whether that's helping the clinicians to identify and score the aspect score much faster or not. But at the same time that we have a number of other clinical trials which were undertaken by colleagues elsewhere in Europe that has shown clear benefits. Clear in the sense that brainomics is performing at par with an experienced clinicians in terms of scoring aspect score. What we can do is, we have a number of papers that we can share with you after that. Actually, the publications that not undertaken by us personally, but other colleagues across Europe that looked at performance of the brainomics, and we're happy to do that after that.
For me, I just wanted to add the one of the papers that was published by Raul Nogueira and his team about brainomics native CT compared to other imaging strategies, compared to CT perfusion and CTA, and compared to MR perfusion. And what you get for anterior circulation large vessel occlusions, you can make a good decision by only using AI and the native CT. and they compared the outcomes, and there was no difference in outcomes between those three strategies in image take, and it was 300 patients for every group, so it's 900 patients. Quite a large study published in 2022, I guess. But I can share it with you, and it's quite interesting because it was made for mostly for Brazilian market. I would say that most of the hospitals don't have access to advanced imaging, and then they wanted to know if the simple imaging with AI can have the same results as the advanced imaging. So it's interesting.
Yeah. Does it also work on MR or not?
Yes, now it's in research phase. We ourselves has a huge interest in taking the Brainomics to the MRI suite, because we're doing MRI for all the patients after the thrombectomy. But for example, in France, they're doing acute MRIs for all incoming stroke patients. We would like to have this system, but we are not there yet with MRI capacities. But we can do for after thrombectomy. Yeah, but it will work with MRI too. Obviously, it's not only for stroke. There are other modules, let's say for multiple sclerosis or for tumor, so automatic detection of multiple sclerosis plaques, and to follow on the patient. So it's a territory that's advancing fast.
Okay, it has been really interesting, and seeing the two systems, I mean, the implementation of Brainomics in UK and Sweden, and definitely it reduces the time and it helps in decision making, as you showed us in the video and during your lunch break. It can be very helpful, yes, definitely. And I guess that it's also helpful to get all the data that is registered on the server, right? So you can go through the 1 year and see all the strokes that you have done, CTAs and
exactly.
CTA agents. You have all the data collected automatically. I don't know if any questions from Dr. Khalil, or maybe the audience, any remarks before we finalize with the takeaway messages? Okay, please continue.
We have a couple of cases to share if you're interested. So both me and Kiruba have some cases to share. But actually, we might not have too much time for those. But what I can share now is what we are doing for the patients with distals, and how Brainomics helps us to identify those kinds of occlusions. So it's one of those cases with a 75-year-old lady with NIHS 13, and it will be a right-sided dominant M2 occlusion, M3 occlusion actually, treated by tenecteplase. You can see the occlusion here on the CTA. And then moving forward for the CTP, which is quite interesting that you get those multi-threshold, multi-parametric Tmax maps when you can see in detail how the collateral circulation is functioning. So what you obviously see here is the Tmax 4s, Tmax 6, and Tmax 8, and Tmax 10. So you can see there is a large chunk of this area which is already in Tmax 10 and Tmax 8 zones. So even if it looks quite okay on the Tmax 6 and you can see a large penumbra, you can predict from those multiparametric maps that this will be an infarction here. So, and even after receiving tenecteplase, the patient the clot was moving more distally. The symptoms were not. The patient didn't get better after that, and you might pinpoint the occlusion here, but this was the occlusion. So this kind of occlusions we are starting to treat in small vessels in patients who have large deficits. So this is the thrombectomy of of those vessels here. Patient got eventually better, so from 13 points went down to 6, but it's most and we can see on the ADC maps that there is a large chunk of this area which is already infarcted, which we already saw on the multiparametric maps. And what's interesting, when you do a measurement in the tracts, then you can see that it will be a large eloquent area in the tract zone. So those tracts are already damaged. So that's why it's good to have like MRI information and maybe the multiparametric information from the CTPs. So it's they complement each other quite well. That's why we are using them. And I just get back to Kiruba's cases because I think he also wants to present something. And I can give you the.
Yeah, I will ask. Yeah. Okay. Yeah.
Yeah.
Okay. Great. Thank you. So this is a case. It's a very straightforward case, but I thought it's a really good one to share because AI did really help us to treat this patient faster. So I think we're not too far away from our memories of COVID-19 pandemic. So this happened right in the middle of the pandemic. You can see April 2020, and that was the first wave. And so we had this movement restrictions, and we don't have any medicines for COVID, and so clinicians were we were infected and self-isolating. So it's one of those things that we can still kind of recall and will be forever remembering them. So this unfortunate fortunate patient, actually, so it's a 70-year-old male. It's a weekend, so you see how our on-call works is that we are here on site, the stroke physicians at front door 9 to 5 weekdays, but weekends we come and see the patients who are admitted overnight for a couple of hours, and then we go home and be on call from home. So that's how it works. So this patient comes in on a Saturday and with a large stroke, and you can see the NIHSS is 2022, and you can see the timing. Symptom onset at 10:40, and he arrived in AD pretty much in an hour's time and had a very quick CT imaging, and images were processed very quickly with the help of AI. So at this time, it's interesting because the consultant who reviewed the patients on the ward is in the car driving back, but another consultant who was actually self-isolating, he was at home. So we did have a system at that time because we know that some of us are going to be taken down by the COVID, so we need to work together. So we did set up a system when a patient is in hospital, the nurse who see the patient at front door will give a WhatsApp message to all the consultants in the group. So whoever is available will pick up the message and then can make the decision, because it was made easy by having the AI, because you have your mobile phone, it's going to ping and get the message in your hand, and when the nurse is called, one of the consultant who was self-isolating responded to the message and reviewed the scans. So as you can see, the alert was 6 quickly responded, and then because they were having access to these 2 images, so you can see the large vessel occlusion and the aspect score 8. So the decision was made to treat with intravenous thrombolysis and also to refer the patient for mechanical thrombectomy. So as you can see how quickly the decisions were made, and the patients actually recanalized at 2:38. So the rapidity of the treatment on a Saturday in the middle of COVID, patient from symptom onset to treatment completion is less than 4 hours, and the patient was discharged 3 days later, fully independent. So imagine, like, how it would have been without the AI means that we would have taken longer for someone to be contacted, and then you need about 5-10 minutes to open your laptop and look at these scans, do the mapping by yourself and calculate the aspect score, and and if the consultant is not at home, you don't carry your laptop with you all the time, so it would have prolonged the process. But having the right images at the right time whenever you need it with the decision aid had really helped us to make the decisions rapidly and help the patient. So another very quick case, just to say how this can also help when you least expecting a stroke patient, because this happened when I was on call for stroke. But we do have a system in the hospital. Every time a patient comes to the emergency department with stroke, we get a pre-alert. So we will go and meet the patient at the front door and take the patient to the scanner. But this happened when I was on call, but I did not get a pre-alert, but I suddenly got a ping on my mobile phone to say that a patient being scanned for a stroke. So I wasn't quite sure how come a patient's being scanned for a stroke when I haven't actually seen the patient. So we do have a system because we do put the request on the electronic system. So when the ED doctor who asked for a CT scan, for some reason thought it might be a stroke, then click the little button. So that means the radiographers would automatically put these scans through Brainomics. That's how I got the alert. So when I looked at the Brainomics images, she can see, because this is interesting because Brainomics is kind of made to work for the anterior circulation stroke. But these are the images I saw on the Brainomics scan. Can you see that the basilar artery, 2 slices, and certainly this looks a little bit hyperdense actually. And then when I went into the patient record on EPR, because I was still in hospital, and said the patient presented with drowsiness, so low GCS. And then when I looked at the examination findings, he was having this myoclonic jerks, left lower limb and problems, and also ophthalmoplegia. So when I went to examine the patients, it clearly came across like a posterior circulation basilar artery stroke. We did the angiogram. So as you can see, the basilar artery is not visible in this slice. And then this is kind of contrast going through. Patient sent for mechanical thrombectomy and had a very good outcome radiologically. But clinically, she took such a long time to get better, but definitely we actually saved the patient's life. So this is a very interesting case I thought I would share, because in this case, the AI pre-alert actually alerted me when the clinician at the front door wasn't thinking about a stroke. They were thinking about seizure or encephalitis, various other differential diagnoses, but the front door clinician didn't even think about it.
هلا بريا مرحبا. كيف امورك؟ ان شاء الله تحيا له مرحبا الله يحييك.
But the pre-alert helped me to intervene and help the patient in a timely manner. So I thought it's 2 interesting cases to share. So I'm going to pass it back to you, Alex. So,
yep.
And yeah, we are happy to have any further discussions.
Okay, Alex, do you still have any images or patients to share?
Yeah, I have a couple of, if you're interested. So I brought some interesting cases. So I tried to just skip those M1 occlusions. So I brought something which might be interesting. It's also more or less a basilar circulation. So it's a 72-year-old lady with a classical SC occlusion with all the symptoms and ipsilateral hemiatexia, pseudobulbar speech, and contralateral hyperesthesia. And these kinds of patients now, after we started to use AI and CT perfusion, they now gets pushed to us. So I was not asking about for to treat this patient, but the neurologist, on the other hand, he was a young and engaging specialist. He pushed the patient because he thought that he was right, that with it can reduce the quality of life of this lady, who is actually a quite active lady doing biathlon still when she's 72-year-old. It's a Swedish national sport when you take your skis and shoot at things. So it's and this was the CT perfusion maps from Brainomics. It's weird in colors because I'm colorblind. I'm not seeing the difference between red and green. So this is my setup. I'm looking at the images like this, but you can choose whatever you want. So we had a clear mismatch. This was made 34 minutes after stroke. And this is the CT angio reconstruction of the image, and you can see clearly that there is no right superior cerebellar artery, and there's small thrombus tail, small clot tail, which is protruding into the P1 segment of the right PCA. So in this case, it was interesting. The treatment itself was interesting because we wanted to avoid when we pulling out the thrombus from the SCA, wanted to avoid to embolize the PCA, which has its own sequelae and which has its own consequences. So in such cases, in the basilar cases, we mostly use radial approach, and it's mostly done by this snuff box approach. That's good when we have cardiologists in close vicinity because they're really pros in such accesses. So I've learned everything from them back in Hungary, but here we also working together with the cardiologist. So you can do it from the radial without any problems. And then you also have better access for those vertebral arteries with large curvatures, and you can avoid to go through diseased aorta. And in this case, we used a high mesh density stent reaver, which is this one, and it acts as a filter here. So when we're pulling out the thrombus from the SCA, it's supposed to prevent the embolization to the PCA. So you can see the wire advance to the SCA, and a small stent reaver, a micro stent reaver, which was deployed in the ST within a combination of an aspiration catheter. So pulling the whole thing out, you can see the immediate recanalization after the first try, and the hyperperfusion in the area, which we see quite a lot after occlusions. And doing discharge at NIHS 0 at day 4. This patient also get an MRI, and you can see a small infarct in the ST region without any bleedings. So for MRI follow-up, we're doing DVIs, T2 flare, and SWI sequences for the bleedings. So I thought it might be interesting to see, and also I get a lot of questions about CT perfusion, how it compares to in radiation dose, because it's a valid question. It's always good to know. So this is our CT rundown for the sequences. So you can see here, this is the native CT taking this much dose, and this is the CT perfusion taking the same amount of dose, and this is the CT angio taking a little bit more of this dose, because we're using low dose CT perfusions for these cases. So that's why we're keeping the CT perfusion with such low X-ray dose. And also, obviously, you can use your CT perfusion images to have 4D angios like this. It's really easy to do, and you have all the informations in your CT perfusion runs. So that's my small take on the CTPs and how we are using it in everyday life with the help of AI. I don't know if you have any questions regarding.
Yeah, it's a question about the last case you showed, radial access. So
Yes.
that was an infinity sheath, right?
Yes, it was an infinity sheath.
So
one thing that, sorry.
It's a 6 French sheath, right?
Infinity is actually 8 French.
It's 8 French guiding, right?
8 French, yes. The
6 French
sheath
sheath
itself is 6 French, yes.
So can it fit with this? I mean, it's like 8 French guiding, as you said. Does it fit here in the radial artery?
I would say that I would not try with everybody, but you must know that the Nordic population, the women and the men, they are much bigger than let's say Hungarians. So I would not use it with in a small Spanish lady, but I would definitely use it in a larger man. But what we are doing in those cases where we are measuring the radial artery, if it's about 2.4, 2.7 millimeter in diameter, then we're using it without any problem. And it's also not only Infinity, it's also the ballast, what we're using now, the BMX from Penumbra, and a couple of other sheets. But mostly for elective cases, we're using radial because it's better for the patient. And we try to use mostly radial for bovine arches. So when the patient coming in with a bovine arch, it's much easier to use the radial access for those patients, like on the left side bovine arch. It's a harder access for from femoral. And
do you use general anesthesia?
We use 70% sedation and 30% general anesthesia. So it's 70-30 split.
And when you have the distal occlusions,
we have, yeah, that is a problem. That can be a problem, but our anesthesiologists, they're very good in sedating the patients. So they're keeping the patients on the edge between general anesthesia and between sedation. They're quite good at balancing the patient. But I would say that if I would work in another environment with the anesthesiologist I don't know, or maybe I don't trust, I would use general anesthesia more. But since we started the whole process with general anesthesia, it was 100% general anesthesia, and we implemented step by step. We implemented the sedation algorithm, and now we are seeing that sedation is working much better for us, and we are avoiding a lot of complications. And also we are avoiding to transfer the patient to the ICU department. So most of our patients after sedation, they're landing on the stroke high dependency unit, but it's not an ICU. So we're not taking up beds from ICU.
Well, I mean, we shared a few cases. We have seen the organization in the UK and region in Sweden. It was very interesting. And as you said, that now it will develop the software for the MR. I don't know if there is any comments from the audience or Dr. Kurdi. It seems that everybody's happy about it.
Yeah, I think this was a very, very informative and very interesting, interactive session that I don't have any more questions from my side.
Yeah. I would like to thank you both, Dr. Alex and Dr. Kiroba, for your very valuable input and this presentation on brainomics. Thank you for joining the Saudi Interventional Radiology Society and the Pan-Arab Interventional Radiology Society. It has been fruitful for us. I mean, we learn from your experience, particularly the drip and ship. It was interesting to see how you manage with the 10-hectare in the peripheral hospital. It's really more practical to send the patient with single injection instead of keeping the perfusion. And I hope maybe we'll meet when we will have maybe a similar system in the future in Saudi Arabia. And I'll finish with thanking Mr. Ilyas Rizk for his contribution, and Medyed for the sponsorship. Thank you for this, to make this happen. Maybe then we'll keep in touch for the future, and probably maybe we'll meet at the ESOC in Germany. Thank you again.
Yes.
Thank you.
Thank you. Thank you very much.
Thank you so much for having us.
Thank you.
Thank you very much. Thank you.
Bye-bye. Bye-bye.
Have a good evening.